All right, we're going to go ahead and get started here. If anyone has any difficulties with hearing me, please feel free to let me know or type it in the chat and we can adjust. So today we're going to be talking about lung transplantation referral and patient selection. I'd like to start off by thanking Dr. Stagner for all of her help that she gave me in guiding me towards the right resources for this project and reviewing things. And then I also want to give a shout out to Drs. Abdullah and Sharma, who helped me with some of the graphical representations and some of the COVID charts that you'll see later on. All right, so because no presentation is complete without a Lord of the Rings reference, my personal favorite, we're going to fly through a lot of information here today, so strap yourselves in. All right, so when it comes to determining what factors make a patient eligible for lung transplant, as you can imagine, there's quite a few things that go into it. It's also important to make sure that the timing of referral is something that we try to aim for and doing earlier rather than later. There's a whole criteria that goes into the evaluation of patients, determining their candidacy, getting them on the list, and any ethical issues that may arise as well. So just a bit of an overview for the field of lung transplant in general. It's a growing field. So you can see here in the chart, this is going about from the 90s to present day, and you know, up and up and up are all we see there. There's over 4,500 worldwide lung transplants, over 260 centers, and this has in part a lot to do with the expansion of acceptable donors and candidates, as well as the fewer absolute contraindications, which have progressed in the various consensus statements that have come out over the years. And how do we select patients? You could probably do a whole talk on that as well, but the UNOS organization has a lung allocation score that they use in order to prioritize candidates to get put on a wait list. Some of the big factors that they look at are waitlist urgency. In other words, what's going to happen to the patient within a year if they do not receive a transplant, and then their post-transplant survival. So what will happen to them if they do get a transplant? And then also what disease category they fall into as well. I pulled up a document on this, and I swear I was like taken back to calculus and class with all the different formulas and exponents and everything that they use. So again, you could probably do a whole talk on that, but UNOS makes it easy in terms of calculator that they have. This is an example with a lot of the variables that you can enter, which generates a score, and then assuming a patient is listed, a higher score puts them higher up on the list, and frequent reassessments can shift where a patient may end up on that list. So a lot of the resources that we're going to talk about today come from the International Society for Heart and Lung Transplantation, or ISHLT, consensus document that was released in 2021. And the main reason that they put this document out was to better identify which candidates would be considered for transplantation, making sure that the timing of referral was more standardized so that all pulmonologists everywhere knew when it was appropriate to refer patients. This also gave a framework for transplant centers to work within when it comes to evaluation and selection. They discussed some general considerations to consider for all patients, as well as some disease-specific considerations. They discuss an ethical framework, which we'll get into as well. And then this I thought was interesting, is that recognizing a transplant center's variability. Certain centers may specialize more in certain diseases, and so they may be better equipped to treat that subcategory of patients, and subsequently may do more transplants for those types of patients at their center. And so just them acknowledging that this is, you know, something that exists out there and is within the ethical framework. And then risk factors, which we'll get into, is another thing that they added for this. So what were the methods that they used? So the ISHLT developed a panel of 24 members, diverse backgrounds. They focused on performing a literature review. It was not an extensive review. It was more focused on documents that came out since 2014, which was the last consensus document, up until the publication of this most recent one. When available, they would use evidence-based research in order to make the consensus statements and the recommendations that they did. However, when that was not available, then they relied on expert opinion. And so all of the consensus statements that you'll see required 80% or more approval from the candidates that were on their panel. So first, just touching base on kind of the ethical framework. So they use a few different things. Utility, namely being that They would like to maximize the net benefit of those who receive the organs. And the definition that they used was years of survival gained. And so the principle of justice wants to also make sure that you're giving equal consideration to all candidates who approach you, that you don't factor in things like social rank, their occupation, their contribution to society. You should not factor into a patient's being selected or at least evaluated for a lung transplantation. Likewise, race, gender, socioeconomic status as well. And then respect, making sure that you have a very transparent process for patients, that they understand what it takes to receive a transplant, that if they're refused, they understand why that is. And so just being very transparent was another component that they mentioned in their ethical framework as well. When it comes to the timing of transplantation, early referral, here at Henry Ford, we have a preference for that. And so the earlier you can get patients plugged in with transplant, the better, so that they have time to discuss things with the patient, work on any modifiable risk factors. That's a huge component as to post-transplant survival. So the earlier they get plugged in, the better. Getting any vaccine administrations before they're subjected to immunosuppression. And then what happens, let's say, if you refer a patient too early? And so here at Henry Ford, we generally will recommend a 1-year follow-up, but depending on the type of condition that they're referred to, so for example, an IPF without any supplemental oxygen needs, we would have a closer follow-up with them in 6 months. And so this is just kind of all going towards trying to optimize the patient as best they can before getting the transplant. These are a lot of the different things that go into the evaluation of a patient, and we'll go into each one of these here as we go forward. And so one of the big things that this consensus statement did was subcategorize different risk factors in terms of which ones would be absolute contraindications for patients, or which ones fall into a kind of a moderate or low risk category. And so this, as you can imagine, is important because patients can have a whole wide variety of variables that go into what makes them a candidate or not. And so knowing where they fall into with those categories, I think, was an important change. So this first one we have here are the absolute contraindications for transplant. And I'm not going to read every single one. A lot of these, I think many of you would agree with as well. The main ones that I did want to point out are that of these risk factor consensus statements that are to come, this was agreed by all 100% of the panel that was put out this statements. And so really no discrepancy when it comes to that based on the 24-member panel. So for absolute contraindications, multi-organ dysfunction, we always think of that as one. But I want to point out that if patients are being considered for a dual organ transplant, this is one situation where a patient may have that and not be contraindicated in order to receive a transplant. So just something to be aware of there. This next category is those that may be deemed at high or substantially increased risk. Again, not going to go through every one on the table. I think a lot of you guys would agree with this, but ECMO was something that was on this list, as well as an EF of less than 40%. And we'll get into some of the specific factors to consider with these patient populations. And then just to be aware of, they did have one more risk category here, which was essentially those with potentially unfavorable outcomes, but that centers can consider these patients dependent on a lot of these center-specific characteristics. And so mechanical ventilation being on this list, and then also I thought was an interesting one, edible marijuana use. The consensus statement had commented that acceptable in the circumstances that this is approved by the physicians, including the involvement of the lung transplant physicians as well. So I'm sure that's just an issue, patients may end up asking about one day with the growing prevalence of marijuana use. Okay, and the ISHLT released some data, so we actually have quite a few charts here to look at throughout the presentation. So just to give you guys an idea, on the categories here are divided by age, BMI, and GFR. And then within each of those graphs, the different colors you can see are those that are done by region. And then on the bottom of the x-axis, it's over time. So the general trend is you can see that, the average age of transplant recipients has gone up over time. The average BMI to an extent as well. GFR, more or less stayed stable. Likewise, a similar graph, this time looking at malignancy there on the left, and you can see that the number of patients with a history of malignancy has increased over time. Those with diabetes that have been transplanted have also increased over time. The smoking parameter or history of smoking, that's stayed relatively stable, which to an extent gone down as well, which coincides with kind of the decreasing smoking incidence in the US. So this one's just talking about age. Again, you saw that trend on the graph that the upper age limit has been more controversial. Previously, it was a relative contraindication in previous consensus documents, but this has become less so the case. Currently, a third of patients on the US waiting list are between 65 and 70, and they have some of the highest transplant rates. They do have comparable short-term survival when you look at the data. However, this is under the caveat that this is a highly selected group of patients, and so generally speaking, they're of the healthier cohort within that age group, and so that may impact survivability comparisons. So just something to be aware of. And then this, I thought, I love ethics and philosophy. So the document had commented that it may be acceptable to consider preference of allocation of a limited resource to a younger patient population. That this would be ethically justified under the principles that we talked about earlier. And then they also talked about something called the fair innings theory of justice. And so this basically says that everyone should be entitled to the right to live a full life. And so potentially prioritizing a younger patient population in that sense may fulfill that ethical principle. But they did acknowledge, obviously, that some of these decisions may be center dependent. And I know that here at Henry Ford, we really focus on a robust, making sure we're giving equal consideration to all people, regardless of their age. And so this is just looking at survivability when it comes to the first year post-transplant in the different age groups. At the bottom there, you can see kind of younger, middle age, and older. And then within the graphs themselves, so the blue line represents data from 2000 to 2005, subsequently the next half a decade on that beige line, and then the green is the most current data that we have. So as a general trend, you can see that we are getting better overall when it comes to lung transplant survivability as a function of time, and there's a number of things that go into that. But you can also just see kind of above that 60-year age group is where you get some comparable survivability rates again, and perhaps a more selected patient population. And these graphs look at 5-year survival, but this is contingent upon the first year survivability. So that's why at the bottom there, when you see that 0 to 1 years, the line stays at 100%. So anybody that lived beyond the first year, those are the ones that are included in the subsequent 5-year analysis. And so again, just noting the differences between the different age groups. When it comes to malignancy, always important to perform age-appropriate and disease-specific cancer screening. If a patient has a high risk of recurrence of death, this is an absolute contraindication for if that cancer were to recur. However, noting that not all cancers are equal, and so coordinating with our oncology teams is important in order to help to determine that assessment for patients. Obviously, it can vary widely depending on stages of different cancers, how long they've been cancer-free, and what you anticipate with subsequent immunosuppression. And so here at Henry Ford, we do have these discussions with our oncology colleagues when indicated. Okay, let's see if I can get this to work. You're on with the quickie bucket, grab me a short bathroom break. Yes, it can. Okay, so no bathroom break quite yet, guys. We're still getting started here. But if that gives you any hint, it's the next topic that we're talking about, and it's about renal function. So increased risk if a patient's GFR is less than 60 at the time of their listing, particularly in patients who are age 45 or older. As you can imagine, there are complications in the perioperative period, as well as immunosuppressive nephrotoxic agents. So all of these things can play a factor into things. And so not that you have to completely exclude that patient population, but again, this is something where you may want to consider dual organ transplant, as we talked about previously. And here's a chart again that Hlt Data. This is looking at those with varying degrees of GFR. On the very right, you can see those that have a GFR above 90. In that middle category, those 60 to 90, and relatively similar survivability rates there. But as you can see on the chart on the left, when you get to less than 60 GFR, there's a noticeable drop off. And so something we consider in our patients. Just a quick slide on diabetes. These are the survivability trends in those with diabetes versus without. And so that earlier chart, and you can see not much difference there as we've gotten better at treating diabetes over time. It hasn't been as much of an implication or factor when it comes to long-term survivability for patients, which is how that earlier slide, you saw the trend that more and more people who are transplant recipients are in fact diabetic. All right, coronary artery disease. So not an absolute contraindication, but it should prompt you to think about additional workup. Patients with CAD are at increased risk of other vascular diseases. They have done multiple retrospective studies that showed that patients with mild to moderate CAD or PCI intervention don't necessarily have outcomes of worsened survivability. Again, caveats being that this is a highly selected patient population and that they potentially undergo single lung transplant. Those with the CABG history, this part I thought was interesting, and I didn't have a good explanation in my mind pathophysiologically, but if anyone feels free to interject. Bilateral lung transplant in those patients had an inferior survival when compared with single lung transplant. I felt that the general trend of everything that I'd read was that bilateral was superior to single when it comes to survivability, but this was just a subcategory of patients that didn't necessarily have that outcome. Okay. Okay, to do a single versus dual. Okay, that makes sense. Thank you, Dr. Singh. Peripheral vascular disease, again, often coexists with CAD. Big limiting factor that if it's in limiting post-transplant rehab, this can limit patients' recovery. And so always something to be aware of. Also limb complications that happen in the perioperative period as well. Heart failure. Right heart failures, they love new sets of lungs, right? You have less pressure that it has to work against, and so patients who have right heart failure often do very well post-transplant. Those with left heart failure, we have good amounts of data that they tend not to do as well. Most transplant centers will not transplant patients with a reduced EF, less than 40%. Connective tissue disease, I thought this one was interesting. Multiple studies show no difference in survival or even allograft dysfunction in carefully selected patients. You can get something called chronic allograft dysfunction syndrome in post-transplanted lungs. There's two subtypes, an obliterans and a restrictive subtype, but if you're carefully selective about the patients, then those with connective tissue disease don't necessarily have any less survivability. Just being careful of what's the condition and what that connective tissue disease may affect in terms of other organs may impact your judgment when it comes to selecting which patients would be the best candidates for that. And then esophageal dysfunction, you get a nice fresh pair of lungs, and all of a sudden you have issues with potentially aspirating into those lungs. You're on immunosuppressions, issues with acute rejections, infections, chronic lung allograft dysfunction. One thing of note, scleroderma patients does not seem to have any impact on their outcomes when they're transplanted in those with centers of expertise. Dr. Steiner was great in educating me about, patients with scleroderma who come to us. They are educated that if they do receive a transplant, then they will require a feeding tube and then lifelong NPO status again in order to try and protect the lungs from any additional insult. Hematologic abnormalities, that's usually limited by the subsequent immunosuppression that comes along with it. And so really you should consider that only in highly selected cases. And then when it comes to BMI, again, we have strong evidence for this. The one little caveat I thought that was interesting was a BMI less than 18.5, almost a third increased risk of mortality. However, the CF subgroup, they often have low BMIs as well, but they have a survival rate that's comparable to other commonly transplanted patients. And so, just not excluding a patient just because they don't meet a BMI cutoff, but again, taking that holistic view of the patient. Likewise, on the other end of the spectrum, a BMI above 35 portends a hazard ratio of 1.9. So again, good data for these as well. Okay, let's see where this next topic is going to take us.
Anybody else speak first? I didn't think so.
All right. Onto the topic of frailty. So often attributable to a patient's advanced lung disease. And so just being aware that this is something that might improve post-transplant. And so it's not always, taking that kind of bigger picture look. There are a number of frailty assessment tools. These have not been shown to be very good at predicting overall outcomes and survivability. And so just being cautious when using those and always emphasis of pre and post-transplant pulmonary rehab. Hypoalbuminemia, again, kind of a cutoff of 3.5. You have increased postoperative complications and a decreased survival while these patients are waiting on the list for transplant. Infectious disease. So this was an interesting part of the article, I thought. So again, these used to be more relative or absolute contraindications in past publications, but more and more so it's becoming less of an issue, and that's attributable to a number of things. As we have advances in diagnostic testing and our treatment modalities, as well as monitoring of disease, this has become less and less an issue so that it is no longer an absolute contraindication. However, it should be noted that these patients still have an increased risk when compared to other transplant patients. And I won't go through every one of these, but these are just the common bugs that we pay particular attention to when it comes to those being at potentially increased risk. Psychosocial factors, absolute contraindications, there's kind of a big three to those. If the patient is non-adherent, if they're having progressive cognitive impairment or active substance abuse, the one exception to that, when it comes to non-adherence is pediatric patients. As you can imagine, they may be at different stages in their development. And as such, we want to make sure that we're including them given that factor and taken into account. Other psychiatric conditions, anxiety conditions, patients on psychotropic medications, not contraindications to receiving a transplant. And the consensus document is very clear that they want to empower individual institutions to use their judgment on a case-by-case basis, making sure to avoid any implicit biases when it comes to this patient population. Likewise, you want a patient to have an adequate support system. And so this was the one area where we try not to take into account socioeconomic factors for patients when it comes to evaluation. However, if in the broader sense, this impacts the patient's ability to adhere to some of these things, then they acknowledge that it may be okay to take that factor into consideration. And so that was just a point of interest that I thought was there. And then just an anecdote that I had to share. I had a patient once didn't have a support system where he currently lived, ended up moving back to Michigan, left his wife in Texas, came to his kids nearby so that he had an adequate support system here so that he could then follow through and report. And so knowing that, you want to try to explain all of these things to patients so that they understand, again, going back to the transparency aspect of the ethics portion. Surgical considerations. So if patients have had previous thoracic surgeries, particularly pleurodesis, this can lead to subsequent issues in post-transplant patients. Almost half of patients who were recipients had undergone a previous thoracic surgery, and they did not find a significant survival difference. The exception to this being retransplantation, which we'll get into, but that subcategory of patients generally portend poor survival when compared to the primary transplant. So you have to be very careful about who you select for those. Those patients with a small chest size, consideration of a lobar lung transplant as an alternative, and then always trying to think of the patient's post-transplant rehab capabilities. So if things cause a restrictive picture, perhaps any spinal deformities, fibrosis, et cetera, these can impact the patient's ability to recover. And so just being aware of that in the setting of potential surgical consideration. So now we're going to talk about just some general considerations. These are kind of some overarching things. We'll get into some disease-specific ones as well. If a patient has more than a 50% risk of death within 2 years or 80% chance of survival 5 years post-transplant, that's a good time to consider referring patients for lung transplantation. Again, emphasizing interval reassessments. Things change. You want to make sure that a patient is in the right location on the waiting list, and that you don't potentially give an organ to them that may have otherwise benefited somebody else. And so these reassessments are important. And then even palliative care referrals, even as the patient is going through the process, to make sure that we're addressing all of those needs in a ways that's consistent with the patient's wishes. Bridging to transplant, so ECMO, which we'll talk a lot about, I'm sure many of us here can report, especially with their COVID patient population, have seen this. Some common indications listed there, contraindications. Again, if a patient has other organ dysfunction, we're generally not putting those patients on ECMO. However, the caveat being that if it's a potentially reversible cause, then you may be willing to make an exception in that case. You would preferably want your candidates up, walking around, and obviously I'm sure many of us have seen those in our COVID populations as well. So retransplantation, I thought it was interesting that up to 5% of lung transplants are those that are getting it their second time around. Again, inferior outcomes, and so this is a patient population you want to be very careful of. Studies have shown, however, that there are acceptable rates of survivability, but in carefully selected patients. And so really understanding why it is that a patient had that initial failure in order to help guide you down the path of consideration of a second transplant. Who gets multi-organ transplants, or what organs do you transplant? So you transplant everyone, all the organs. So it's about 1.6 of lung transplants are those with dual organ transplants. No Leon the professional fans here. Longer wait times and a higher waiting list mortality are associated with those that are receiving multiple organ transplants. They tend to have a worsening perioperative period, but they do have favorable long-term survival, as you can imagine, correcting two insulted organs. When it comes to heart-lung, pH is the main indication. And then when it comes to lung-liver, those with cirrhosis with an elevated portal gradient, but again, making sure to take in patients with hypoalbuminemia as well, those with ascites or encephalopathy, not necessarily considered for dual transplant. Lung kidney, that one was one that had a very comparable 1 and 5 year survivability, even when you compare that with other patient populations. So next we're going to talk about disease-specific considerations. And so just to give you guys an idea about what percentage of patients and what diseases they have that are transplanted, you kind of have the big three. So towards the bottom here, you can see again, I'm sorry, it's a little bit grayed out, but over time, the different conditions that are receiving transplant, and then per region. And the big three, IPF, COPD, and CF, as you can see, they compromise almost 2/3 of lung transplants. Retransplants, again, that's small sliver, and then some other conditions that we'll talk about as well. So the first one we'll talk about is COPD, and you'll see this kind of table throughout my presentation here, but essentially they release these consensus statements. On the left column, you have the older consensus statements, but what we really want to pay attention to is that middle column. And then on the right, they tell you how many people of their 24-member panel agreed with that consensus statement. Most of these have, excuse me, anywhere, again, meeting that 80% threshold or above in order to make these statements. So when it comes to COPD, using the BODE referral, using PFTs with monitoring of their FEV1 in particular, that's when you may want to consider the timing of a referral for patients. And then when it comes to listing a patient, these are some of the indications that would prompt you to then place a patient on the transplant list. And again, just that BODE index, just knowing that it may overestimate mortality, that there's a shown survivability benefit in those patients that are having an FEV1 less than 20. You want to take additional factors into play if patients have PH or chronic hypercapnia, how frequently they're having their exacerbations admitted for it and the severity thereof. Knowing that DLCO is not a predictor of mortality in COPD, but that you can still use it for consideration of prompting you to refer patients for transplantation. And then also taking into account a patient's quality of life as well. So these are the survivability trends in patients who are transplanted with COPD. Again, on the left here, we have a 1 year survivability data, with the green bar being the most recent, and then on the right, conditional 1 year survivability, and then subsequent 5 year survivability. Okay, I always like to throw in one of these puzzles. This one's probably not the best one, but I did the best I could. So if anyone wants to take any guesses as to what the next slide might be about based on the jokes. No guesses, huh? Okay. All right, the first one's not the best picture, but let's say Duffman can't, it was a Simpsons joke, so I felt I had to insert it, but if we're calling the first one lungs, the second one is maybe did I hear it, maybe? No, second one, maybe the volume is too loud. And then we're gonna take it down. No, just me. All right, that was bad. Sorry, lung volume reduction, so. All right, so knowing what patients that may be a benefit in, that it can postpone the need for a transplant. You can have patients then have subsequent improvement in their functional or nutritional status. Being aware that pleural adhesions have led to longer transplant operative times. And then there's been conflicting studies showing the survival impact in patients post-transplant when it comes to those that have had previous LVR. And so I think being cognizant of specific patient populations that may have a true benefit from this, those with advanced emphysema, upper lobe predominance, decreased exercise capacity, those are the ones that may have the most benefit from LVR procedures. And then some of the benefits there, again, that we touched on. So, correct, yes. Okay, IPF. This was one that I thought, and again on the left here are the updated 2021 consensus statements. This one I thought was interesting because these patients are known to have a potential for rapid decompensation. And so you often don't have that luxury of time of monitoring the disease progress moving forward and noticing that downwards trend to get them plugged in with lung transplant referral. So they actually recommended that all patients who receive a diagnosis be referred for lung transplant evaluation, which differs from a lot of the other conditions that we're going to talk about. And then some of these cutoffs for when they consider referral, so FVC of 80% predicted or DLCO under 40, these are very high numbers compared to a lot of the other conditions. Or if they've had interval decreases of certain thresholds, you should definitely consider referring these patients for transplant evaluation. I think the big takeaway I took about was that as more and more antifibrotics are becoming the mainstay of therapies in these patients, you're reducing the rate of their FVC decline. And so they tend to have a better survival benefit, decreased exacerbations. So, maybe in time to come, we'll see less of that being an issue here, but these are the consensus statements as of now. Excuse me, when it comes to non-IPF related ILDs, studies are still ongoing as to whether antifibrotics may be a benefit in that patient population. And so just again, using kind of traditional markers when it comes to consideration of referring a patient. So that was, I thought, an interesting topic. Here again are some survivability graphs when it comes to IPF. I thought this was pretty remarkable. Again, that green bar is pretty spread out compared to the older data that we have. And when you consider that in the setting of the newer treatments that are now being, that we're able to offer these patients, I think that the data reflects that. All right, cystic fibrosis. So this was the most consensus statements out of the different conditions that we're going to talk about. I won't go through and read every single one of these, but again, just kind of want to point out an overall trend when it comes to FEV1 using 30% as a cutoff for when you consider patients for referral for lung transplantation. In the pediatric patient population, you use a bit higher cutoff. And then again, if you're noticing trends in the rate of decline, taking into account other factors, all these things can be used in consideration of referring CF patients for lung transplant. In this patient population, the FEV1 has been shown to be the best predictor of mortality. Once it falls below 30%, they have a survival of 6.6 years, median years, and a 10% risk of death each year after they fall below that threshold. So again, a lot of data showing that definitely you want to get patients referred for transplant evaluation at that time. This has not always been the case because it's been kind of difficult to determine that. And so those CF patients don't always get referred in a timely manner, which is a part why I think they came up with a lot of these consensus statements and really try to emphasize this and drive this home. Transplant in all CF patients, you want to be considerate of MDRO organisms, their nutritional status. Again, that BMI cutoff does not apply as much to this patient population because they have comparable survivability rates post-transplant. And then just making sure you're also performing age-appropriate cancer screening, but that CF patients are at increased risk of colon cancer, and so you start cancer screening that patient population a bit earlier. Again, some survivability data at 1 year and 5 years in regards to CF patients. Again, as we're getting better and better with the treatments, again, I thought this was another one that the most recent data reflects that as well. Okay, non-CF bronchiectasis. So this comprises about 2.5% of patients. Again, kind of the consensus statements notes that similar criteria to those with CF, but recognizing that these patients may have a more stable course in consideration of their disease. So there's a couple of score categories that they use. One is the FACIT score. This takes into account those items that you see there. That one they showed was a better predictor of a patient's overall prognosis. And then another score is the bronchiectasis severity index that kind of takes into account the above factors, but they also add in BMI and frequencies of exacerbation when it comes to that. That one was shown to have more predictor of disease severity. Again, you'll see a common theme here. FEV1 less than 30, they have a much higher mortality rate. And so getting those patients plugged in once they've crossed that threshold. And this one here kind of makes sense. Those, when you compare it to bronchiectasis in patients with CF, this non-CF patient population, they have a lower risk of death overall, lower risk of mortality when you're compared to the CF group. And this was even taking into account that those patient populations had similar lung function tests and following them forward. Pulmonary arterial hypertension, again, a number of risk calculators that have thought to be of use. If a patient's on maximal medical therapy, if they're needing IV prostacyclins, if despite these escalations in therapy, patients still aren't improving, these are times to consider referring a patient for consideration of lung transplantation. If there's any Encanto fans, I'm sure you'll appreciate that one. So early referral before they decompensate. Of note, apparently many lung allocation scores don't fully capture that kind of waitlist mortality that is specifically associated with PH patients. Excuse me. And so, using systems that prioritize these are important. The 2018 World Symposium on Pulmonary Hypertension, they released their recommendations for when a patient should be referred for lung transplant. And again, kind of using those two models of assessment, if patients have failed to achieve low risk status after 3 to 6 months, intensify their therapy. If it's not achieved at that 6-month mark, you want to refer these patients for lung transplant eval. Group 3 PH, you prefer a bilateral lung transplant in them, and those with congenital heart disease, you should consider repair if able, otherwise consideration of dual heart lung transplant. And so this is that PH data, again, that green line at 1 and 5 years, that green line is the most recent data. And again, I think this coincides that we're getting better at treating these patients in the post-transplant setting, as well as the medications and things that we have to offer to these patients, I think are improving over time. And so, I foresee that trend continuing when it comes to many of these patient populations. Lamb, who wants to take a guess at what abnormal lung function FEV1 cutoff you send these patients in, again, 30%. This is becoming more and more rare as their treatment modalities have changed for it. But you want to refer these patients again in the following subcategories: FEV1 less than 30, those with exertional dyspnea with an NYHA class 3 or 4, or if they're hypoxemic at rest. Particularly this patient population has better post-transplant outcomes when you compare it with patients with other pulmonary disease. And again, this is another patient population where you want to take careful consideration of a bilateral lung transplant as opposed to a single. If you only put in one, the other one's got a bunch of holes, potential for pneumothorax, and then complications thereof. And so bilateral transplant strongly considered in these patients. When it comes to malignancy, again, rare that we're having to do lung transplants as a result of malignancy, but consideration of which candidates may be most appropriate for that. Those with the following lung cancers are those that you should consider, but just understanding that this potentially has a high risk of recurrence, and so this is very center dependent when it comes to consideration of that patient population. All right, and onto some interesting ARDS and COVID data, which we have some Henry Ford data to contribute to that as well. So when it comes to those with ARDS on mechanical ventilatory support, if you do not expect clinical recovery and they have evidence of irreversible lung damage, obviously those are the patients that we want to consider for lung transplant. So rarely is it feasible to perform the full transplant evaluation in these patients. I'm sure many of you have seen this, especially in our COVID patients. And so trying to assess the possibility of recovery without a transplant, understanding that this patient population often have many favorable factors, such as a young age, no comorbidities, the fact that their pulmonary causes the primary cause of their ARDS, and then the COVID data is still forthcoming. At least per the document, from the consensus document, experts in the field recommend waiting 4 to 6 weeks after the onset of respiratory before considering them for lung transplantation. And I think oftentimes we do that earlier, more in the acute setting, but when it comes to post-COVID fibrosis and as such, that data is still forthcoming. And so, still too early to make any conclusive statements onto that. However, for Henry Ford, we can at least say some things about the patients we transplanted here. So when it comes to COVID-19, patients will generally fall into 3 categories of potentially needing a lung transplant. That is acute COVID ARDS being the reason that they need the lung transplant. If a patient has a chronic underlying lung disease and then COVID comes on top of it and pushes them over the edge. And then lastly, long-term sequelae of post-COVID fibrosis. And so UNOS, the data that they had was at 134 lung centers transplanted cases between October and May of last year. And 48 of these patients underwent lung transplant due to post-COVID lung fibrosis. And again, I want to thank Dr. Stagner and Dr. Sharma for helping me with retrieving some of this data for Henry Ford's patients. So here we had 4 patients fall into that. I'm sorry, go ahead. Excellent, excellent. Well, thank you very much. Okay, so some more updated data than what I had here. Thank you very much for that. So out of curiosity, how is the post-COVID fibrosis patient doing in the long term?
Well, we are last consultation month.
Okay.
You'll see in our post part of that example, but as far as I want to do that.
Great, thank you very much for sharing that. Just for those of you out in Zoom land, we have some updated data for this. So 11 patients with COVID transplanted total, including 1 with post-COVID fibrosis that was just seen in the clinic last month. So of the data that I had here, but overall favorable outcomes. There was 1 patient on this list that did not survive the hospitalization, but on the whole, I think some favorable data when it comes to that patient population. Okay, last thing just to, again, that the consensus document discussed was about the variability that can occur between different lung transplant centers, and understanding that a number of things go into play here. So consideration of the local circumstances, accreditation requirements. So as you can imagine, if a program is just getting started out or they have a smaller volume of lung transplants, they may be more particular about those that they choose to transplant versus perhaps, let's say, a higher volume center that can maybe afford to take more risks. And so understanding the consensus statement understands that there may be some variability when it comes to that and acknowledging that. Different governmental policies, different organ availability within a specific region, different centers may have different risk thresholds that they're willing to accept. Different centers may have different expertise when it comes to different lung conditions. And so kind of all of these things taking into account, understanding that, the bigger picture when it comes to performing lung transplants in the US. Transparency, again, a big thing when it comes to the ethical portion, making sure that we're clear on criteria, clear on if patients are refused, why that is, and what may change that then allow them to be considered in the future. And then not to end on a sad note, but Transplant Tourism was a document that, or a phrase that I'd saw in there and I hadn't heard it before. And I said, oh, that sounds like something fun. Not so much. This is highly frowned upon. It's when you travel to another region and potentially for money purchasing organs essentially. And so they just had a statement on that is not something that they condone in any way, shape or form, but just to familiarize those with the term. Did pretty good on time here. So in conclusion, the consensus document really helped to highlight that outcomes vary significantly based on a patient's characteristics. So you want to try and take that into account, knowing that the risk factors, there's different categories for them, that they're often multiplicative in nature, and that it's just not an additive risk when it comes to considering those. At different centers with different areas of expertise may have different risk thresholds, and that's okay. Being transparent with patients, as well as the information that we provide as an institution. Early referral for patients really is a big thing. This lets you, again, optimize their modifiable risk factors, which yield the most successful long-term outcomes. So, my philosophy that I kind of took away from all this is that, when in doubt, or as early as you can, I think sending these patients in for referral. And then just kind of looking towards the future, there's a lot of research, a lot of different treatments that are coming out in regards to a wide variety of diseases. And as we get better and better at treating these diseases, it's good to have more and more research and evidence done so that we can use that in order to guide our further recommendations moving forward. And so with that being said, any questions? I didn't see anything myself.
on the error rate there, doesn't go that high because it.
Thank you very much.